Good evening, aspirants. Today class is about EDIC Part 1, Fluid Electrolyte, which would be conducted by Dr. Manmohan Bose. He's a consultant intensivist and in charge of AHRC hospital in Ranchi. His area of interest is in neurocritical care endocrine emergencies.
Good evening all. I'm Dr. Manmohan. Glad to be here. This will be a discussion thing. So you have to answer, you have to ask the questions. So don't think that I'll just read the questions and answer and just read the explanation. So before going to the answer, I'll be asking you why not answer A, why not answer B. That's the way I do it. Let's start. So this the previous lecture was about theory covered regarding the electrolytes and fluids. More of it is electrolytes. So for EDIC 1, electrolytes are very important. So be it sodium, potassium, calcium, magnesium, phosphorus. This all 5 electrolytes are very important. If you ask me among 5, which are the favorite for EDIC 1, it's a sodium and calcium. There will be 1 or 2 questions for sure out of 100 questions regarding the electrolytes, some way or other way. Okay, either a straightforward question or indirect question, maybe either in A type or in K type. If it is in K type, there will be single question about just one electrolyte, or there will be options regarding particular electrolyte arrangement. So electrolytes, you need to be very thorough. So first thing, it is important for individual electrolyte abnormality, as well as it is important for ABG calculation, ABG for anion gap and osmolar gap calculation. So please don't ignore this. And as we practice critical care, we do see electrolytes reports day-to-day basis. We do correct electrolytes day-to-day basis. So this part, though it is not ignored one, but I would say though we do see it on regular basis, people don't give much of importance while preparing for the exam. But practicing electrolytes management versus theoretical theory about the electrolytes are a bit different. You need to know a bit more regarding the electrolyte correction and electrolyte causes that we don't usually use in practice. So that's why I'm trying to convince you guys that you need to know few specific points regarding electrolytes theory. So I would try to cover maximum theory and while discussing those answers regarding those particular electrolytes, I would try to cover the other options also, so that in one question we would try to solve 2 or 3 questions. That's the goal. So I have taken some 26-27 questions. So let's begin. If I am taking extra time, you can ask me to move forward. I can go ahead and we'll try to cover up it in 90 to 100 minutes. Okay, let's start. So first section is about A type, and second half is about K type. So how many of you know difference between A and K? Everybody knows about A and K difference? A type and K type? All of you are aware of difference between A type and K type, right? The marking system for A type and K type. I'm not seeing any response. Okay, let's start. So type A, we'll start with the type A. Type A, there will be 5 options. You have to choose one most correct answer among the 5. And if you get it correct, you'll get 1 mark. If you don't get it correct, you'll get a 0 mark. There is no negative marking. It's regarding the exam. So let's start. A 68-year-old man has been brought with a history of collapse several hours ago. He was found to be hypothermic at 32 degrees centigrade. His creatine kinase was quite high, 9,000. His potassium was 5.1 and urea was 22 millimoles. Creatine was raised 310. The most important initial treatment should be, what would be the most important initial treatment? Answers from the candidate.
Intravenous infusion of warm crystalloids.
Okay.
Yeah.
Any other answer? All of you A?
Yes, sir.
Okay, good. Correct. So that's the right answer. Very good. So general crystallite should be, and because he is hypothermic, so warm crystallite should be the choice here. Okay, active warming is important, but before giving intravenous fluids, if you try to actively warm him, that will actually further worsen the hypotension because of the vasodilation. his potassium is though above the normal range. Okay, his potassium was somewhere 5.1, but that doesn't require urgent dialysis. If you give him fluids, maybe that will correct his potassium as well. Okay, you'll be wary of giving IV fluids which are high content of potassium, like ringer lactate and others. So you'll be careful about giving those ringer lactate. You'll be preferred fluid of choice will be normal saline or balanced crystalloids. Okay, any doubt regarding this?
No, sir.
Okay. Second question. A 74-year-old male, history of diarrhea and vomiting, confused, complaining of lethargy, tingling in his hands and feet. While being transferred to the hospital, he suffered a brief self-terminating seizures. On arrival, his examination shows muscle weakness with positive 𝐄𝐥𝐿 signs, Rosse's sign, ECG shows ST depression, T wave shows flattening of U waves, QTC was prolonged. Which is the primary electrolyte disturbance? Can explain all these findings.
A.
Hypokalemia. Okay.
Hypocalcemia.
Okay,
No,
both
sir.
are right.
Hypomagnesemia will explain all of them. Right?
Yes, correct. Super. Good. See, the 𝐄𝐥𝐿 signs and Rosse's sign, if it is just that's the thing mentioned in this question stem, then you can go ahead with the hypocalcemia. But there are T waves flattening and U waves plus QTC prolongation. So T wave flattening and U waves and ST depression, all these are signs of hypokalemia. So the signs of hypokalemia and hypocalcemia is both are there. So there is history of diarrhea, vomiting, lethargy. Okay, all these things will actually fit in hypomagnesemia. So before correcting hypokalemia, before correcting hypomagnesemia, if you try to correct potassium and calcium before correcting a magnesium, it won't help much. You have to give magnesium first, and then simultaneously, if you find calcium and potassium low, you will correct both. Okay, so but the primary, which one electrolyte explain all the abnormalities is the magnesium. The answer is E, magnesium. Magnesium is essential mineral, important for bone mineralization, muscle relaxation, neurotransmission. So hypomagnesemia can affect any system in your body, as it is so important. Ignored electrolyte, we don't give so much importance to magnesium on day-to-day basis, but it is important. If you find any patient who is getting deteriorated for without any reason, don't just get away by checking sodium, potassium. Please focus on magnesium also. So causes of hypomagnesemia can be polyuria, diarrhea, prolonged vomiting, large nasogastric aspirate, inadequate intake like a starvation, parental nutrition. Clinical features, as I said, it can affect central nervous system, can lead to confusion, irritability, seizures. It can affect CVS, can lead to arrhythmias. The hypocalcemia, hypokalemia will be resistant if you don't correct magnesium first. So prior to correcting those calcium and potassium, you need to correct magnesium. The combination of signs and symptoms of hypocalcemia, hypokalemia are suggestive that the problem is magnesium. So correct magnesium with IV correction. Okay, question number 3. A 47-year-old gentleman admitted to the hospital for a long time. He develops hypophosphatemia, hypomagnesemia, and hypokalemia following the introduction of enteral nutrition. What is the most appropriate next management step? Answer, please.
E, sir, potassium replacement and continue enteral feeding, allow shift of electrolytes from total body stores to renal liquid.
Okay, any
Agree.
other?
E is right, I'm agree as well.
B for Bombay.
E is.
Okay, any other answer? So you want to start, so the first candidate answer E answer, I heard that. Second candidate answered B for Bombay. He wants to replace the electrolytes and stop internal feeding. Any other answer? Okay, there are answers on the chat. Okay, did anybody answer C? You can unmute yourself rather than let me go on chat. You can unmute and say the answer. That will be better for me. Madhvi Bhumiti has answered C. Huh?
We will make electrolyte replacement C and we will reduce enteral feeding.
Super, very good. So that was That's the right answer. So you don't stop the enteral feeding. Okay, the option B is wrong. You don't stop the feeding. Okay, and option A is also wrong. You don't continue the same amount of enteral fluid. So why all these electrolytes will get decrease in your intravascular compartment? This patient diagnosis is what? First, tell me the diagnosis of this patient.
Refeeding syndrome.
Correct. So as you said, it is a refeeding syndrome. So what do you think? In refeeding syndrome, there will be only hypocalcemia? In the question itself, I have mentioned there is a hypomagnesemia, hypophosphatemia. So you won't bother about just the potassium alone. You have to replace the phosphorus, you have to replace the magnesium as well, right? So E is wrong, though they have mentioned the mechanism in option E, but the correcting of just potassium alone is not enough. Okay, so you have to correct all the electrolytes, and while doing that, you need to reduce the feed, not containing the same amount or not to stop the feed. You need to continue the feed, but before doing that, you need to reduce the feed and correct the electrolytes, all the electrolytes, whether it is a phosphorus, calcium, magnesium, or potassium. Understood?
Yes, sir.
Clear, clear. Thank you.
Okay, good. Okay, so that's what the diagnosis was, refeeding syndrome. See, before going to answer, I'm trying to cover the explanation as much as on the options itself. So my whole funda, even if they have some modification in this question, see the EDIC, what strategy we have to use. You don't have to read much of theory. The theory topics are more or less same. Okay, it will be always about hypokalemia or hypercalcemia. It will be always about hypomagnesemia or hypermagnesemia, but the question stem will be different. So by ruling out other option, why other options are not right, by doing that you will be considering other answers also. So even if the question stem is different, you will be able to answer. So I'm not going to explanation directly, I'm just discussing the option and then I'm going to discussion. So explanation, you can read it later on also by watching the recording, but here we want to discuss it. So that's why I'm discussing the answer in the question itself. Okay, so it is a refeeding syndrome, and why it happens? Because when you malnourished patient, when you feed them more than, even if it's a normal calorie requirement, okay, you don't need to feed them with a supranormal calorie requirement. Normal calorie requirement, even if you try to feed them, there will be insulin surge, and whenever there is insulin surge, it will push your electrolytes from intravascular compartment to intracellular compartment, because when he was malnourished or nutritionally depleted, there was a electrolyte shift from intracellular compartment to intravascular compartment. So intracellular, already all electrolytes are depleted, so whenever there is insulin surge, these electrolytes will be shifted to intracellular compartment. So there is sudden drop of electrolytes in intravascular compartment, so that can lead to arrhythmia, can lead to multi-system involvement. As I said, magnesium can affect any system, so even that can lead to. So that this commonly happens in surgical patients. They will be NPO for few days, then they go undergo, before the surgery, before coming to the hospital, they'll be NPO because of the abdominal pain and distension, perforation peritonitis. Let's take a perforation peritonitis. So before getting admitted, he was not taking feed for few days, admitted, operated, post-op he was NPO for few days, and then day 7, day 8, you start him on internal or parenteral nutrition. So 7-8 days is good enough to cause electrolyte disturbance. So when you start the feeding at that point of time, the patient is at risk of refeeding syndrome. So you need to be conscious about electrolytes. So you need to recheck your electrolytes every 24 to 48 hours and be sure that you are not causing any electrolyte abnormality because of the refeeding. Okay.
Sir, you have given E as the answer.
I'm so sorry. Is it so? One second. Huh? No, I'm sorry. The answer should be it should be B. Okay. No, sorry, B, not B. It should be C. The answer is C. Okay. I don't know. It was a mistake. Sorry for that. The answer is C here. Is it clear to all of you? It's a typing error from my end. I'll just correct it.
Clear.
Yes.
It should be C. Okay. You don't stop, you don't correct the potassium alone, you reduce the feed and you correct all the electrolytes. Okay, sorry for that error. Thank you for correcting me. Type K, you will get 4 options. If you get all 4 right, you'll get 1 mark. If you get 3 right, 1 wrong, you'll get 0.5 mark. Trust me, even 0.5 is important. Okay. If I'm saying that, that means it is very important. The reason for that, one of my junior failed EDIC 1 just by 0.5 mark. Okay. The thing is that it happened in April session last year, not last year, this year only. Okay. Not this year, last year. I'm sorry. Last year, the cutoff was 57.5 and he got 57. Okay. So it was too bad for him to lose the exam just by 0.5.
So how many marks we get for K type?
When you can mute yourself because I'm getting echo. Okay, yeah, I'll answer that question. So the K type, if you get less as possible, that's always better. I always love A type because the probability of getting it right in A type is always better. So when it used to happen on on-site basis. So the Indian center was Kolkata. So before 2020, there were approximately 60-40 was the ratio. Okay, but for last few years, in last 2 or 3 years, the ratio has gone down. The K type has reduced to drastic extent. I was lucky when I appeared in 2021, the K type questionnaire was just 16 for me. I got 84 A type and just 16 or 17 K type. Okay, but before that, there used to be 35 to 40 K types. So nobody can give you the exact number how many K types, but be prepared. Approximately 30 questions can come. If it is less than that, good for you, because it is difficult to score in K type. The problem with K type, even if you know 1 or 2 options, you need to know all 4 options. Okay, whether it is true or false, you need to be very sure before answering those 4 options, and you always get one or other wrong. So, and when you go into K type, the time is already limited. You are already rushing through the questionnaire, so you don't have much time to think. So in a hurry, you do answer a possible correct answer also wrong. So time is a one problem in K type, and understanding the each option is also other problem in K type. So if you are lucky, you will get just 20-25. If it is tough luck, you may get around 30-35. Okay, it
Marks
used to be there. Yeah.
How many marks, sir? How much we do get? If we get 3 correct.
30-35 questions means 30-35 marks approximately. Okay. Each question will have 1 mark. Okay. And the cutoff will vary on the top based on the topper. Whatever the topper is there, based on that they will decide cutoff. So there is no exact no cutoff for each session. The cutoff will vary. Sometimes it will be 50. The cutoff varies between 55 to 62. Okay. The cutoff varies between, sometimes it can go up to 62-63. So if you want to be in a safer range, you always try to score above 65. Okay. Till now, the highest cutoff has gone up to 62, if I'm not wrong. Okay. Never gone above 62. So those who are in the range of above 65, they get through. Okay. So when you are giving mock tests, when you are trying to solve your questions, try to be in the range of above 65. Okay. That will be the safe range. Let's start with the type K. With respect to tumor lysis syndrome, what are the options are true and what are the options are false? So it will be confusing to listen true, false, true, false. You can type your answer like in a sequence, true, true, false, false, true, false, true, false, like that. If you want to answer, go one by one. We'll increase the bit. I have 11 questions of K type. We can finish it off in another 40 minutes. High dose intravenous steroid therapy is reasonable initial treatment option. Is it true or false? Do you give steroid in tumor lysis? It's false. Clinical TLS can be diagnosed with a seizure and appropriate life findings. Is it true or false? Go one by one. Answer. Everybody is silent. At least type or just unmute yourself. If you are going one by one option, is it true or false?
True or false? True, sir.
True. Okay. Okay. A is false. B is true. What about C? Increase
True,
serum calcium. in and potassium level by 25% is the hallmark. Is it true?
True, sir.
Sir, hyperkalemia.
Yes, hyperkalemia is there, but what about calcium? See the calcium. See, they play with English also. Don't be in a hurry. See, this is the greatest good example of rushing through the options when you have limited time. You see hypocalcemia, you don't see hypercalcemia, right?
Yes, sir.
So C is false. Allopurinol is the treatment of choice to prevent AKI. True or
False.
false? What do you use? Huh?
True,
False.
sir.
True, false, both. One said true, one said false. It's false. We use raspberry case. Okay. So among 4, only B is right. All other are false. Okay. Only B was right. Other 3 were false. So I have formulated a discussion in such a way that we discuss one by one option. So tumor lysis is life-threatening. It usually seen in a hematological malignancies. Okay. Okay. So hypocalcemia is the hallmark, not hypercalcemia. And ionized calcium will form because with the phosphate. Other laboratory findings, there will be raised in more or less. You should be very through with the laboratory abnormalities in TLS and rhabdomyolysis. Okay. One or other question can come in some way, or either in A-type or K-type. Drug acting to prevent formation on uric acid like allopurinol does increases but doesn't have a role in prevention of AKI. Steroids have no benefits. IV fluids and raspberry case is the treatment. But if I have an option of 2 and I have to choose one best option for a treatment of tumor lysis, what will be? I have given, like, there are 2 options given, IV fluids as well as raspberry case. What is the next best step? What will you choose? Will you choose raspberry case or IV fluids for tumor lysis?
IV fluids.
Yes, it's IV fluids. Yeah, good, correct. Causes of hypercalcemia. See, we solved one A-type question regarding hypercalcemia. What does loop diuretics do to hypercalcium?
Sir, thiazide, they cause hyper.
So loop diuretics is a false, right? Yeah, so A is false. What about men type 2?
True, sir.
See, type 2B again. It's not a men 1 or men type 2A. Men 1 and men type 2A will have parathyroid hyperplasia. Both will cause hypercalcemia, not type 2B. Okay, that is again false. Hyperthyroidism, true or false?
True.
False.
False. True, false, both I heard. It is actually true. Not only hyperparathyroidism, hyperthyroidism also can cause hypercalcemia. Immobilization, pretty easy.
True.
Does it cause hypercalcemia?
True.
True.
Yes.
It is true. Yes,
True.
immobilization causes hypercalcemia. Yes. So C and D is a true. A and B is false. Okay, that's the answer. A, B false, C and D true. So the commonest cause of hypercalcemia is a primary hyperparathyroidism due to parathyroid adenoma. Okay, and as a part of men syndrome, men 1 and men 2A, not 2B, men 1 and men 2A will cause hypercalcemia. And malignancy, sarcoidosis, we are all aware hypercalcemia. Other rare causes of like vitamin D mediated thiazide diuretics, as you said, theophylline toxicity, lithium toxicity, vitamin D excess will cause hypercalcemia. Immobilization is a rare cause, but yes, it can cause hypercalcemia because of the excess bone resorption. Hyperthyroidism, it is a recognized cause of hypercalcemia, though less common than hyperparathyroidism, but yes, hyperthyroidism does causes hypercalcemia. Raise anion gap metabolic acidosis causes. True,
Renal
false, true, false.
True,
So,
sir.
yeah, true. Lactic acidosis.
True, sir.
True.
A, true, B, true. C,
False.
very good. D,
False.
very good. All other people agree?
Yes.
See, I want proactive interaction. I am hearing 2 or 3 people noises. Okay, rather than echoing, please answer. Okay, let it be healthy discussion. Even if you get it wrong, doesn't matter here. Okay, but you'll be sure what is not the answer. Okay, so A and B is true, C and D is false. Yeah, so this table I have deliberately added. If you want, you can take a screenshot of it. Okay, these are the most commonest, or there are multiple mnemonics. Mud piler for high iron gap metabolic acidosis, and one more mnemonic for non-iron gap metabolic. If you remember that, that is also good enough, or this is also good enough. So all these are the most common, most important causes for high iron gap and non-iron gap metabolic acidosis. Okay, so yes, A, B true, C, D false. In renal failure, there is a failure to excrete unmeasured organic acid, so, and lactic acidosis will cause high iron gap metabolism. Pancreatic fistula, because of the bicarb loss, there will be non-iron gap metabolic acidosis. Urinary diversion, everybody is aware of that, because of the chloride ions, the bicarbonate will get exchanged, and that will lead to non-normal iron gap metabolic acidosis. Any questions till now? What we have solved? We solved 16 questions of A type, 16 or 17, and 11 questions from K type. I wanted to cover 30 questions, but I could not prepare other 3-4 questions. Sorry for that, but we are on time. So, like, any doubt, any tips you wanna discuss, we can discuss it here. Or you wanna guys close it? We'll close it.
Sir, please provide me the formula for correction in hyponatremia, along with that is the for calcium hypercalcemia.
For sodium correction in with relation to sugar,
Hypercalcemia.
yeah. So for just easy purpose, we calculate 200 minus like sugar minus 200 divided by 2. Okay, so if sugar is 400, so 400 minus 200, that will be 2 divided by 2. So it will be, the answer will be 2, right?
Divided by
100,
2.
sorry, divided by 100. I'm sorry, divided by 100. Okay, sugar level minus 200 divided by 100. So if it is sugar level is 400, minus 200 will be, so 400 minus 200 will be 200 divided by 100, that will be 2. So you will increase the sodium by 2. The corrected sodium will be 2. Regarding the calcium, corrected calcium for albumin, every 1 reduction of albumin we have to raise calcium by 0.8. If the albumin is 3 instead of 4, the normal level for albumin is 4. If your albumin is 3, so that means you have to add 0.8 of calcium. So if your calcium is 7, so your corrected calcium will be 7.8. If your albumin is
7.8.
No, I did not understand. Hello?
No, I
Yeah,
mean,
did you
I
understand the
7.8. Maybe
I'm sorry.
connection.
So the calcium correction, every every 1 decrease in albumin, we have to raise the calcium by 0.8. Okay, if it is 3, you will raise the calcium by 0.8. If albumin is just 2, you will correct the calcium by 1.6. If it is 7, that will be, the corrected calcium will be 1.6. Okay, you can just Google all these formulas. For the sodium also, it's not exactly the same what I said, but for practical purposes, this is what I use. But for the exam purpose, try to use the exact formula. That, okay, it's always beneficial. Okay. So, yeah, somebody in the chat, important difference between TLS and rhabdomyolysis. Yes, the electrolyte disturbance is more or less same, but the cause for the condition is a peculiar. In rhabdomyolysis is different. The TLS, there will be always malignancy. After chemotherapy, it will happen. Okay, the treatment, the primary treatment will be always IV fluids. Drugs, here in TLS, you do give raspberry case. Here in rhabdomyolysis, you alkalize the urine with the bicarbonate and all. And in both the scenarios, if the electrolyte abnormalities are getting worsened, if the AKI is getting worsened, you consider dialysis. Okay, the differences, if you ask me, it's a etiological difference is more important. Okay, otherwise the electrolytes abnormalities are more or less same. The etiology is different and treatment is little bit different. Okay, thank you.
Okay, thank you.
Thank you.